Welcome everyone. My name is Carolyn Williams and I'm the General Manager of Community and Corporate Relations. And it's my pleasure to welcome you to Behind the Discoveries. And today our theme is giving our loved ones a second chance. In the spirit of reconciliation, we acknowledge our traditional owners and we acknowledge their deep connections to culture and community. We pay our respects to elders past, present and emerging. And we extend that respect to all Aboriginal and Torres Strait Islander people who may be joining us here today. Just to commence, I'd like to do just a few of the housekeeping duties. So your microphone will be muted throughout the duration of this webinar. And just to let you know that this webinar is being recorded so that we can share it with others that haven't been managed to join us today. Please do submit your questions via the chat box, which is down the bottom of your screen. And now it gives me great pleasure to introduce Steve Moneghetti. Steve is probably very familiar to many of you. He is one of Australia's all-time greatest marathon runners, having represented the country at 4 Olympic Games, 4 Commonwealth Games, and 6 World Championships. He has run an incredible 22 marathons and finished in 11th place or higher in 22 of those. Steve is also the uncle of Dr. Kegan Moneghetti. So if you were noticing the similarity in the surname, you're exactly right. Steve happens to be Kegan's uncle, and it's a great pleasure that we welcome him here today. Steve has generously agreed to step in for us just kind of at the last minute. Unfortunately, our ambassador, Matt Kegan, is sadly attending a funeral today and couldn't join us, but we are delighted to have Steve and celebrate the family connection. So without further ado, I will hand over to Steve now.
Thanks, Caroline. Yes, lovely to be here. I am indeed Kegan's uncle. It's funny because I'm normally, I'm introduced as Steve Moneghetti, but today I'm just Dr. Kegan Moneghetti's uncle. So it's great to be along on the webinar. I'm no Matt Keenan, but I'll do the best I can to get some information across today and share with you, and there'll be some great learnings in it for me as well. So I'm looking forward to it. I suppose I could say I'm really proud of Kegan, and I would honestly say that he is my favourite nephew on that side, on my side of the family, and that's a fact because he's actually the only nephew on that side of the family. But seriously, obviously, I've seen Kegan grow up. He's always had an interest in sport. I do remember him telling us at a very young age that he was going to be a doctor, and then his involvement in sport as a really keen swimmer and a very good breaststroker, I might say. Swam at country Victorian championships and played hockey at a high level here in Ballarat, and then for some reason, I'm not sure why, decided to do a bit of running as well and has become a very competent distance runner, so much to my joy. And I know he's always wanted to be a doctor, but we as a family could not have ever imagined how successful and how much he's giving back to the community in his work, and we're really proud of him. So it's terrific to be along today, and I'm looking forward to hearing some insights into his work in the cardiac area. More formally, Clinical Associate Professor Kegan Moneghetti is an academic cardiologist with a key interest in exercise medicine, cardiac imaging, and precision health. Kegan's current research focus and projects include the integration of exercise testing into diagnostic pathways and translational studies identifying biomarkers that differentiate those people at a greater risk of cardiovascular events. And Kegan actually worked in the US, as I know, at Stanford University, and did a lot of work in the sporting field with teams in America. And I thought maybe as an introduction to you, and welcome, Kegan, could you say would be the difference between the US system and how we operate here in the understanding of heart disease?
Yeah, well, thank you so much for that lovely introduction. And it's absolute pleasure, I was saying, to be interviewed by yourself. I think it's super exciting to have a bit of a family connection here. So thank you for stepping up and being part of this. It's lovely to be able to kind of share this with you, particularly with your background of elite performance. The fact that we're here discussing exercise, I think it's a privilege to have you here to even shed some of your insights from the science to kind of really being at the on the field and experiencing probably some of the cardiac physiology at the end extremes. To link in with that first question, kind of the US and Australia, I think foremost part of why a lot of fellows and lead researchers spend time overseas is to develop kind of further skills. But I think also what is good to go overseas is also that we see that we do things very well here in Australia. With regard to cardiovascular disease, we really do have some of the leading institutes, the Baker being one of them. The way that we interact with athletes, provide screening programs and assess and treat those people who are highly active with cardiovascular diseases, really on par with university institutions like Stanford, where I was, and other prominent universities in the field. So I think we can be very proud of that. In contrast, I think that we're very lucky here in Australia with the universal healthcare system that we have equal access for everyone to really be able to modify cardiovascular risk. And I think a lot of the research that we might even touch on today, or that we perform in elite athletes, then can really be rolled out and can have meaningful change, not just for those high performing people, but people who are maybe sedentary or just trying to exercise for the first time.
Yeah, mate, it's sort of like the Formula One, a lot of the technology that's developed in Formula One, then we see that transferred into our vehicles that we drive. So similar, to use a sporting analogy.
I think it's a great way to look at it. I think it's important that our Formula One program here has kind of almost been set up by Andre Lagersh with a large cohort of athletes, and that's been fundamental to a lot of the other programs that have started to develop here at the Baker, and then hopefully infiltrating into other fields. So.
And it's interesting because Andre, being a marathon distance runner himself, and yourself, so I'm seeing this link. I think it's always a benefit if you do have a personal experience. All of my experience is anecdotal, but even in my own circumstances, off the back of COVID, there's a lot of interest in myocarditis, especially in younger athletes, and we've had conversations offline, to be honest, about that effect and how it's affecting elite sports people, but just the general population. And I always worry because I think is it scaring people away from exercise, and can you reassure people that hey, it's exercise is still okay and fine, and from a heart perspective, it's a good thing to do.
Yeah, no, I think that there was really a call to arms in the early stage of the pandemic about, concern and protection for our, professional athletes and those who are highly active, because there's some initial data that was coming out showing this inflammation in the heart, or myocarditis. Some of that call to arms was both here in Australia, and some of my work across at Stanford was also looking and tracking collegial athletes. And as time went on, we started to see some reassuring signs that, the severity of this heart inflammation, or the amount of people or athletes who are being diagnosed with, was actually probably lower than we initially thought. And so, we always want to be cautious, and, people with cardiovascular symptoms in the vicinity of any virus should obviously seek medical attention. But by no means are we seeing these kind of long-term issues in mass with inflammation in the heart, which I think is good. And then we've got a lot of large programs both here at the Baker and nationally, then looking to follow up, not only athletes but other people, and the issues that may come with viral diagnoses.
Yeah, great. So almost having a sample size is allowing us to get feedback, and over time we'll get more information and be able to provide more information back to the general population.
Yeah, I think that is what has been, really reassuring, that the ability of us to collect mass data and through large collaborations share that, and then be able to kind of communicate that with the public close to in real time, which I think has really been, one of the things that has come out of this pandemic about being able to accelerate research, express and communicate that research to the public, which I think, part of these forums and, one of the kind of fundamental things that the Baker strives for is to try this kind of communication and disseminating research to consumers, patients and people so they can reap the benefits early on. Yeah.
Great. Now, we could chat all day, I know,
yes,
as we do, but I know more specifically today we're looking at statistics showing that someone who has had a heart event, so say a stroke or a heart attack, is actually at a high risk of having another heart event. And so, when you talk about giving our loved ones a second chance, I mean, it's exactly that. So why is that the case?
Yeah, so that's a kind of fundamental question, and that people asked early on is why is these people having heart attacks, having further heart attacks, and there is a number of key causes. The first one is the process that causes a heart attack can't be fully reversed in these patients. So if someone has had a blocked artery, it's likely they have some other partial blockages elsewhere, could be in the heart and elsewhere. So a lot of the treatments will open or treat the major blockage, but that residual mild to moderate blockages will still be there. And so these patients are still at higher risk than someone who's never had a heart attack. The other issue that is a great challenge for patients is a lot of the lifestyle and environmental factors that cause their initial heart attack, everything from being sedentary to smoking, still remain. And we do our very best to change them, but obviously change has its challenges, as we all know. And so we really need to look at ways that we can treat that underlying disease, and then ways that we can support our patients with lifestyle modification and risk factor modification. And that's how we're going to really reduce these rates of secondary events, which is just so important because it's many-folds higher chance that these patients are going to go on and have another heart attack.
Yeah, and you can take a horse to water, but you can't make them drink. So do you also work with the sort of wider family? Because to get a lifestyle change, it's often, if someone else maybe is doing the cooking, or, you've got friends who are probably got a lifestyle that's not quite as conducive to, they're all out having great time. Suddenly you've got to go, oh, I can't have a great time anymore. I've got to. So do you kind of educate some the family as well and support networks?
Yeah, so that's where one of the focuses today is cardiac rehabilitation, and that's where it can really play a role. So with anyone who's in the audience today who has either had a heart event themselves or been closely involved with a family member, they'll be aware of this kind of, very, bombarded with information when they're unwell. A lot of things are happening in the hospital setting, and that's just not the time where you can do further education, begin to process what has happened. And so early cardiac rehabilitation, which often happens in the community in forums like this via, Zoom or recently, gives the chance for kind of reinforcement of lifestyle modifications, checking on medications, and then exploring, those environmental factors. Could it be, the family support? Could it be, the inability for some reason to conduct physical activity that might be holding them back from their secondary prevention strategies?
So that's happening now. So how can we better incorporate this into our healthcare system? Because I think it is happening now, but probably not as effectively as we'd like.
Yeah, no, so cardiac rehab is definitely happening. And we know that there are a number of organisations, both from our tertiary hospital networks to community organisations, who are strong supporters of cardiac rehab. But there's just so many touch points along the line where we can improve this process, which has already been shown in widespread clinical trials to reduce secondary heart attacks and improve patient outcomes. And so ways we can do that is engage with these patients really early. So one of the trials that we'll be conducting beginning next year is looking at very early cardiac rehab. So actually people commencing regular exercise programs within days to weeks of having their heart attack under supervision, which is obviously very exciting. Hopefully we can make a difference. We've had a number of clinical trials in integrating technology into cardiac rehab. So gone are the days where you have to come to the doctor's office or into the actual physical program. to have a connection. And if we have increased frequency of touch points, we might be able to modify behavior to a greater extent. And then fundamentally is funding and advocacy. So, obviously we need to look at ways that we can creatively fund these programs, make them efficient, and be able to connect, with people who, may not necessarily have been connected with before through cardiac rehab. So these are kind of three, I guess, really key areas where we can really improve the process and the delivery of these types of programs.
It's interesting because I kind of think of, I remember when I was young once, believe it or not, and people would have knee surgery. I do remember. And people would have knee surgery, and I remember they'd be in a massive sort of cast on their knee, and they, weren't allowed to sort of, they weren't allowed to do anything for months, and then it kind of progressed to where, you'd get on a little exercise bike almost straight, you'd be wheeled out of the theatre and straight on the exercise bike to get that rehab happening. So it's great to hear that's, that's kind of the method that you guys are using as well. So yeah, that's good feedback. And with the, is there any, like for people out there now, like you say, is there anything new or, rather, you mentioned about that sort of continual follow-up, Zoom calls the capacity now to have interaction at a lot more effectively. Is there anything really new that's suddenly you go, oh, look, this is what we're doing. We found great results and people are responding better to this little trick that we're using?
Yeah, so look, there's probably two main things that's worth highlighting here. And first is just the actually spreading the indication and the relevance of cardiac rehab. So we've actually, one of our groups here led by Erin Howden and Steve Folks has recently published physical exercise programs having benefit in patients undergoing chemotherapy in regard to cardiac function. And so I think it's very exciting to see that we can reproduce some of these results that we see in just cardiac patients in non-cardiac modalities. Again, just reaffirming that exercise is medicine, not just for the heart, but also elsewhere. And the second thing that's very exciting is really this personalized approach to cardiac rehabilitation. Everybody obviously has different genetics. That's why my marathon time is slightly slower than yours, but also probably, a little bit of training too, obviously, but people react to exercise differently. So we're starting to have the tools now through more complicated exercise testing, like cardiopulmonary exercise testing, to really identify maybe what heart rate thresholds or what degree of exercise people might be able to benefit from most. And as you can be, if you've just had a heart attack and you've got other ailments or fatigue, if we can optimize the timing and type of exercise that you're doing early post your heart attack, that could have a really meaningful, difference in outcome.
Yeah, that's great advice. And I have athletes that I coach using heart rate monitors for exactly that. They're often people who overtrain, so it's to keep them sort of limited, but I can sense that for feedback and for controlling the level of exercise that you're getting a person who may have had a cardiac incident, then that's really valuable. And, we never know, and it is individual, but the more feedback we can get and control, we can probably have, I think, from me personally, especially remotely, a lot of the athletes I don't see, I've never actually met that I coach, but so to have that feedback information is almost, it's as personal, it makes it so much more personal now, and we can do that via technology. So great. Now, I know we have got some questions that have come in. I think one we had from Johnny, what is new in cardiac assessment of athletes? I think we've covered that a little bit. Is there anything you'd like to add to that, Kegan?
Yeah, I think the, one thing, and some people in the audience and John may be aware of, the concept of an athlete's heart, and a lot of referrals and people we see both in our research programs and in the clinic are trying to work out, are these changes that are happening in the heart to do with heart disease, or is it just physiological remodeling? So I think what is exciting that really over the last 5 to 10 years, the technology in the ability to image the heart, particularly with cardiac MRI, has become so detailed. It's really helped us differentiate these two conditions to give us more confidence when someone might be experiencing heart disease as opposed to cardiac remodeling. And secondary to that, genetics is playing a bigger role. Here in Australia now, we're getting more access to cardiac genetic testing, and the ability to do that testing early, especially in someone who has findings that might be suspicious of heart disease, which can be very common among athletes, can really help us differentiate disease and give the best possible recommendations.
Good answer. We do have a question, current question from Heather. Dr. Kegan, are you able to comment on the emerging view that obesity isn't an individual issue, but that we are victims of structures like the food industry, supermarkets, manufacturers, social planners, etc., who seek to influence consumers to buy unhealthy products and or live in areas with no parks or green spaces?
So, wow. Great question. A lot to unpack there. I'm gonna take this. I'm gonna take this from a few. We'll look at it from a few angles. I think first, there's clear socioeconomic data to show that if you are from a lower socioeconomic group, your rates of obesity are higher, and that is probably a structural problem. There are environmental inputs there, like just having the time in the day to be able to exercise, the availability to have healthy food choices and control what you're eating all play a role here. And that really comes back to the fundamental principle of how do we assist and support people across all types of demographics and backgrounds in their lifestyle modification. And I think that we overuse the word personalize, obviously in research in medicine, but I think really what we're trying to do is how do we help that individual in front of us? And I think that that question is trying to kind of pull on that, is that we within this structure, we need to find ways to support people in making lifestyle change. But there's also actual genetic inputs into obesity too. These do play a role, just like people's exercise training has different effects. If people on the same caloric intake sometimes can have different effects on their weight. And this is something that we're getting better at understanding and might help guide people. So look, I don't have a clear answer for that question today, but I think yes, there's definitely structural problems, and our job as clinicians is to advocate for people and to find ways to work within this structure to improve their outcomes.
No, it's a bit of a team effort. I think that's such a social and cultural question that we probably need to influence a few other people, and where your work's one aspect of that, I think. Another question we had, and it's quite a long question from Jocelyn. I recently developed ventricular ectopics, 15%, and all cardiac tests done were fine, but an MRI of the heart was inconclusive due to the ectopics. But there is a scar on the left ventricle. I've always had BP, blood pressure on the low side, no problems with that. I'm a believer in exercise to retain my schoolgirl figure. I had my second COVID vaccine August 2021, and since December 2021 have recorded low pulse rates around 40 at different times, and the machine recorded irregularities, activity off and on. I've since had the third and fourth COVID vax. Will this lead to further heart disease?
What great detailed question. Lots again to unpack there. Okay, so I think let's talk a little bit about ectopics and great work with the pronunciation, Steve.
I got there in the end.
Yeah. So ectopics are extra beats in the heart. These are really, really common. In fact, a lot of our referrals to the clinic, and we will see people who have like a palpitation or a skip beat. And it's in the minority of people where these really are a problem. In short, ectopics is just the backup electrical system in our heart. It's just the manifestation of a good electrical circuit. Sometimes when that electrical circuit gets a bit excited, people have a lot of these beats and they become, quite burdensome. That may have been the case here with Jocelyn. And you can often try and find areas of the heart there that are causing the problem. There are lots of different options to try and treat these types of ectopics if they're troublesome or burdensome. And typically, exercise is not always contraindicated. What's really important is to probably touch base with a cardiologist and do some type of physiological assessment to see if these beats are getting worse with exercise. And often, if they're not, with a bit of counselling consultation, it doesn't necessarily mean that you cannot exercise even to a high level.
Right, thanks, Kegan. I remember Rob De Costello. I remember chatting to him, and he used to skip a beat, and I started sort of getting aware of mine, and mine did the same. I often thought because we were so fit that our heart could afford to skip one, and we saved a few for later. It was good positive thinking by me. So I'm sure there's no evidence that it was unusual for us both to have that heartbeat where we skipped a beat occasionally. We do have another. Is that good or not?
No, that is good. And actually, we do find athletes actually, for two reasons, are a little bit more aware of their heart. One, they have increased vagal tone. So the brake on the heart's very high from all the training. And it gives more opportunity for these extra beats to come up and have a go. So it's not uncommon to see these in athletes. And the second thing, just because your body is your profession, you are probably just have a greater awareness too of these extra beats in your heartbeat. So in other people who may not feel them, you probably are quite aware of these extra beats, but in the vast majority of people, they're not harmful. So,
no, great, thanks. And Heather said thanks for the response as well. Trudy had a question. What is the best way to prevent type 2 diabetes and heart disease? And obviously, type 2 diabetes is a growing concern with general society. So that's from Trudy.
So type 2 diabetes is one of the major cardiovascular risk factors, and it is modifiable. Obviously, identifying that people have diabetes to start with and then treating it. So how would you prevent it in the first instance? Well, as with cardiovascular disease, there are things that we can't change, like age. As you approach 50, you're at higher risk of diabetes. Family history is also going to put you at higher risk. So in those people, speaking to your GP and getting screened is important. Things that modifiable that you can do, there's crossover with cardiovascular disease. So ensure that you maintain a normal weight. So if you're calculating your BMI, making sure it's between 20 to 25. Being physically active. So aiming for our 30 minutes 5 times a week of moderate physical activity will definitely reduce the risk of with diabetes too. And all of that is going to not only reduce the risk of diabetes, but then reduce your risk of cardiovascular disease too. So you get 2 for 1 with a lot of those risk factor changes.
Yep. We have a question from Jenny. I have genetic cholesterol and find it hard eating fish and salads, though I do eat a low saturated fat diet. What are the statistics around secondary heart events following blockage of RCA, which is right coronary artery, I think? Is that, if my terminology is correct?
Your terminology is spot on. We might have to give you an honorary MBBS today, Steve. So your right coronary artery. So for those who aren't over their coronary anatomy, 2 major arteries, right and left in the heart. The left one's larger, it splits into 2, and in the majority of people supplies about 2/3 of the heart, and the right one tracks around kind of the back of the heart, so what we call the inferior section of the heart. So look, if you've had a blockage in the heart, that is really an example of where secondary prevention is so important. So identifying all the risk factors, hopefully going to a cardiac rehab program, and getting back into physical activity. Diet is hard, and it plays a fundamental role in the management of cholesterol, like the foundations of a house, and then we add extra treatments on top, like certain medications. But ultimately, we are genetically programmed to process cholesterol in certain ways, and despite people's best effort of fish and salads, they may not necessarily reach the goal for their cholesterol. But if thinking of diet, unprocessed food, if there's one message I can give you, just try and cut out anything that's processed to start with. Fresh fruits, vegetables, whole grain, protein-rich foods, using your healthy fats and oils, and then of course watching portion size are all things that are going to help. And then this is where it can be useful, if you need something more granular to engage, like a dietitian or more specific dietary advice. And then it might be, especially with the blockage in the heart, that if you don't meet the guidelines, targets for your cholesterol, it may not be because you're doing the wrong thing. It might just be that genetics that you're born with, you might need some extra help with some medication.
Gosh, I love your practical answers. You don't get caught up in terminology and even a simple person like me can understand it. Kegan, good work. And we do have a comment. I work in cardiac rehab, and so brilliant to hear a cardiologist advocating for patients to attend. We still struggle to get some patients to engage, and when cardiologists tell them they must attend, this works. Clap, clap, clap. So thanks for that comment.
And thanks. Just highlighting one of those touch points of of where we're trying to research and improve, because and that might be referring them early, or doing early rehab, or having that cardiologist educated so they give positive reinforcement for the patient to attend. So these are all areas of innovation that we can explore.
Yeah, and it's such a serious area, and I'm just coming as a naive person on this webinar today, but it's a fear thing sometimes, and especially often for males. And I notice a lot of our questions are from females. Males tend to be, we're too tough to guide, that'll be right, we'll be fine, and then you kind of worry a bit, and you're probably scared to attend. So making it a welcoming environment and talking about prevention and practical steps is really valuable. We do have an example as well through Baker and Alfred back in 1993 after bypass surgery, joined aftercare 6-week rehab program, which was wonderful. This included a buddy who was at the same stage of recovery, and that was great support. And that's from Ruth. So do you have a buddy system that maybe can, because I know if it's Ballarat, it's freezing cold in the morning, don't want to get out and train. If I know somebody's waiting for me, I get up and go. So I think that buddy system can work well here as well.
Oh no, absolutely. And part of cardiac rehab is it's multi-modality, and we focus a lot on the physical activity component through exercise prescription and building up people's exercise intolerance. But the fact that you're in this program with other people, having that connection, sharing stories, maybe even holding each other accountable to turn up next week because your friend's going to be there. They're probably all aspects that can be difficult to tease out what's contributing from a research perspective. We do our best through certain statistical techniques, but as a whole, all these modalities together is probably what's driving the improved outcome in these patients who are attending high quality cardiac rehab.
And I often think you feel like you're sort of isolated, whereas if you're in a group, you kind of get this, actually someone else is having issues the same as me, we can discuss it, and maybe I've been through something that someone hasn't yet, and you can provide advice. So that sharing of information I think is quite reassuring. We're often very self-focused, and whilst we're talking about a really serious part of life for us all, sometimes we get so self-focused we forget, and having other people in the group I think can be really valuable. It's not about me though. Another question, I'm from Carol, 65 years old, fit, not overweight, not a smoker, very little drinking, 4 stents in that RCA, right coronary artery, 40% blockage in the LAD, the left anterior descending artery. Cardiologist says no more marathons because of high risk of rupture. Who agrees with that, please? Well, not me, but I'm not the doctor.
Well, I would... I obviously commenting on specific cases is hard, but up front, our whole, ethos in sports cardiology, has changed, over the last 5-10 years, and we're about empowering people to exercise. So instead of saying not exercise, I guess the way that we would approach it is why not exercise. Obviously, you're having a very good relationship with a cardiologist who has an interest in exercise, or sports cardiologist is fundamental if you want to kind of reintroduce that, higher intensity or, endurance exercise post a heart attack. And look, there is some epidemiological evidence in large studies to show that, endurance, training at very high levels may, lead to greater acceleration of atherosclerosis. But, this is in very high volume people, and obviously that not usually representative of the population. We do worry sometimes in people who are doing long marathons about all the other things, or endurance exercise, all the other things that are going on, dehydration, electrolyte imbalances, which can all cause some sheer stress or extra tension on the arteries. But if you have a strong secondary prevention program, you've been screened appropriately with physiological testing, you go slow in the reintroduction of exercise with, under the supervision of a cardiologist, it's possible to achieve, running a marathon. And I think it's important here that everyone's marathon is different. So, for someone that's 42K, but for someone else, the marathon might be, going for that, doing a park run on a weekend, or it could be, just being able to walk around the block with the grandkids. So I think the actual distance and exercise modality, I think thinking about things that granular is often not helpful. I think, what does the person want to achieve? How do we control of our risk factors, minimize risk, and then it kind of empower that person to achieve what they need to do? Should be the flow through the pathway.
Yeah, so I sometimes think I sometimes think it's, they want to sort of get back and prove that they're still capable. But you got to remember, the marathon was a made up distance, happened to be from where the Battle of Marathon was to Athens, 42K. No one picked it, and it's just a long distance. Unfortunately, it's too long for a lot of us now. So, it could have been 30K. We would have known any, or 20. It just happened to be 42.2, as it turns out. When they ran from the London Olympics, they changed the course. It's only 40 in Athens, but 42 in London. So a marathon's not the be all and end all. It's great that you set your own goals. We do have just a couple of more minutes. I'm keen to get through some questions. One from Marie. Marie says, does exercise help diastolic dysfunction? I think she means exercise. I don't want to excise her diastolic dysfunction. Will exercise help her diastolic dysfunction, Kegan?
Yes, that's a great question, and something that is under a lot of research. So for everyone in the audience, so diastolic dysfunction is, we have two kind of cycles of the heart. We have systole, where the heart muscle is contracting, and we have diastole, where the heart muscle is relaxing. And they can form two different types of heart failure. Unfortunately, diastolic dysfunction, or problems with the heart muscle relaxing, is far more difficult to treat. And we don't have as many options as with problems with muscle contraction. So there have been some larger trials that have shown some improvement in diastolic function of the heart, and improvement in overall exercise capacity and well-being. But it's thought that this may not just be to do with the heart muscle itself, but actually kind of development or of further muscle strength peripherally. And so, to be honest, I think that the jury's still out on centrally how much is kind of regular exercise really affecting diastolic dysfunction. However, an important point to raise, exercise does modify a lot of the risk factors and the perpetuating factors of diastolic dysfunction. So even if we get to show really strong associations with diastolic dysfunction in exercise programs, we are showing strong associations with modifiable risk factors for that. So definitely still strongly recommended, and overall is going to increase well-being. So a great thing to do.
And that's a good update. It's obviously current thinking. So thanks for that. Not sure how we're going. There's a good question here from Mike. This might be final one from me. How long does a stent in cardiac artery last, for example, in the LAD? Should there be any limitation to exercise with a cardiac stent? Any interaction with warfarin and heart health, for example, drugs to be avoided?
So actually, that's a great question, and it kind of raises a few points. I think, look, one, innovation in cardiology and technology has been developing at such the pace that 10, 15 years ago, stents would have minimal life. Now they can be drug coated, which improves them. The actual technology in their design has improved. There's even some work being done here at the Baker validating absorbital stents, so stents that actually absorb, into the heart tissue itself. So there's no true, use by date of a stent. It all comes back again to this secondary prevention to keep it working properly, making sure the cholesterol's controlled, controlling your blood pressure, and preventing further heart events is going to be fundamental. And kind of as the last question about marathons, similar thing here. It's not just because you've had a stent, it's not a contraindication to endurance activity, but it's really important to focus on those secondary prevention measures, engage with practitioners who are interested in heart health and exercise, and kind of set a goal or a plan to get back to where you want to be.
And just finally, a bit about the interaction with warfarin and heart health. Is there any drugs that should be avoided? Yeah,
so not specifically. Warfarin thins the blood to try and prevent certain complications of heart disease. So it's often prescribed to, improve people's well-being. There's always certain, issues with blood thinning, especially in contact sports. So that's something definitely you always want to talk about with your practitioner. But again, these things often can be modified or discussed to accommodate patients, goals or wishes, particularly when it comes to physical activity.
Great. Okay. Well, our time's up. We've done well, and really, I think we've covered a lot of really good information. They're great questions. I think that's the thing. People obviously really engage. This is an area that's of great interest. So thanks for being so honest with those responses. And if we didn't get to your answers or your questions, it didn't answer them, the Baker Institute will follow up with responses to your questions. So, and we have recorded this webinar today, so it'll be available if you want to spread the word and let anybody or hear it again or pass it on to anyone, then it'll be available. So thanks very much for your attendance. We do have a reliance on your support to ensure the work of the Baker Institute and researchers like my nephew Kegan can continue. So after hearing about the fantastic work of Kegan today, it'd be great if you could consider making a gift to our current appeal and help us beat Australia's biggest killers together. And you can see that QR code on the screen. So feel free to take a screenshot of that or take a photo of that, and your support would be really, really helpful. So to all the donors and supporters out there, we appreciate you tuning in today and look forward to getting some feedback from you, which there'll be a short survey that'll be emailed to you in a few days' time. So hopefully you can respond to that as well. Feedback would be great. Obviously, we can make sure we're tailoring these webinars to areas of interest, and we hope you've got a lot out of today. I certainly have. It's been a delight to catch up with Kegan again, and I hope you've got some values out of it. And behind these discoveries, we are indeed giving our loved ones a second chance. My name's Steve Moneghetti, and it's been my pleasure to host you today. We look forward to having you join us next time, probably, I think, May next year, and you'll probably Maddie Keenan back for that one. We'll learn more about what's behind the discoveries at the Baker Institute.